Great. So thank you everyone for joining us today and welcome to this treatment session entitled Treatment Innovations and Adaptations. We have two really fantastic presentations for you today. We will have a Q&A and discussion at the end following the two presentations. So we look forward to that discussion. My name is Nicole Bono. I'm the Senior Treatment Advisor with USAID in the Office of HIV/AIDS in the Pediatric Maternal Branch. And for this panel, I'm working with Megan Schwantz, our local partner coordinator, who is right there, Nimasha Fernando, who's helping manage the Q&A in the chat box, and Kelsey Oliver, who is the note taker. So our presentations today focus on two aspects of HIV treatment. The first presentation is on demand creation and the implementation of U=U in Haiti. And the second presentation is about scaling up and optimizing pediatric treatment during COVID-19 in Malawi. As you know, growing and sustaining ART is a priority for USAID and you, our local partners, and you are critical to that goal. We know the COVID-19 epidemic has been a challenge to maintaining our recipients of care on treatment, and these two presentations share important aspects of optimizing treatment, that is communication and education, as well as treatment optimization through dolutegravir and lopinavir for children. I'd like to introduce you to our two panelists. The first is Jean-Claude Luis. Monsieur Jean-Claude Luis is a Haitian national with extensive experience in the development world, addressing cross-cutting communication issues related to gender, environment, climate change, HIV/AIDS, and human trafficking. He's coordinated the implementation of many empowerment projects for vulnerable groups in Haiti. He's currently the coordinator for the Institut Panos, a local partner funded directly by USAID in Haiti. Mr. Luis has been a pioneer in supporting associations of people living with HIV to strengthen their capacity to advocate against stigma and have a voice in decisions affecting them. Mr. Luis was trained in sociology, journalism, and public relations. The second presenter is Dr. Joop van Oosterhout. Dr. Joop is the clinical director at Partners in Hope Malawi, a local medical NGO. At Partners in Hope, he oversees clinical aspects of a PEPFAR-supported care and treatment grant. After a period as general medical officer in a rural Zambian district, he completed specialist internal medicine and infectious disease training in the Netherlands. He has been based in Malawi since 2001 and has been closely involved in the Malawi HIV program from its inception in 2003. He has combined frontline clinical and programmatic work with implementation research, built on questions from the field and aiming to influence policy. He holds a position as physician at the David Geffen School of Medicine, University of California, Los Angeles, and an honorary professorship at the University of Malawi College of Medicine. Before we ask Mr. Jean-Claude to get started, I would just remind everyone to ensure they're on mute unless they are speaking, asking a question during the Q&A session. And I see that we've already started with introductions in the chat box. Thank you for that. We look forward to hearing your questions and contributions at the end. And at the end of the session, we will identify a few key takeaways to share with a larger group. So at this point, I would like to hand over to Mr. Jean-Claude Luis to present. His presentation is entitled Haiti, E=E, U=U campaign, a behavior change campaign to increase ART awareness and adherence in Haiti. Mr. Jean-Claude.
Thank you very much, Nicole. And I would say good morning. I mean, it's early morning here in Haiti. And good afternoon for those in the other part of the world. Well, in Haiti, we would say A=A or U=U. It's a behavior change campaign to increase ART awareness and adherence in Haiti. And we do this campaign to increase awareness among people living with HIV and AIDS. Could we go to the next slide, please? Okay, so this is a project that is being implemented in collaboration with the Ministry of Health and the funding of USAID. And it is done by the Panos Institute. Panos is an old Greek word that means lamp, or we would say flashlight, where people are gathered around to discuss important issues. We do work through the voice of the poor and the marginalized to make sure that they are participating in the debate, make sure that they voice their concerns. Can you move on with the slide, please? Okay. You can move on with the next paragraph. So we do work on a couple of thematics that transcend national boundaries. I mean, we do work on child rights, HIV and AIDS, environmental degradation, gender, and
can you still hear me?
To development challenges. And in the field of HIV and AIDS and tuberculosis, we make sure that we involve the people who are infected, the people who are really concerned, to promote participation, accountability, and the response to HIV and AIDS. Can you move with the next slide? Okay. Usually we know that people who are vulnerable, they are impacted by those issues, and we make sure that they are able to produce their own information. This is what we do as panels. Let's move to the next slide, please. Okay, keep going, please. Okay. Okay, well, we are Haitian. I mean, we are in the Caribbean. Haiti has a population of 11.4 million, based on data provided by the United Nations. The last census that was done in Haiti dated over a decade, so we're not too sure of these figures, but this is the most recent figures that we have. And then Haiti is divided geographically in 10 departments. And the West Department, where the capital Port-au-Prince is located, has 35% of the Haitian population. And in Haiti, there are approximately 155,000 people that are living with HIV and AIDS, and some 72% or receive antiretroviral therapies, but only 60% of people living with HIV and AIDS are achieving a viral load suppression. And there is a huge number of people who are lost to follow up. So there might be many reasons for this, because sometimes, you can mention, the political instability. People have moved from one place to the other place. And when we were to launch this project, so what we did, we organized a series of focus groups with people living with HIV and AIDS to gather information, to know how we should move on with the campaign. And some of the reflection mention a lack of knowledge about ARVs, in French, ARTs, treatment, and its benefit for the well-being. And also the people living with HIV and AIDS, they feel a lack of trust from healthcare workers and providers, because very often what happens when they go to the clinics, before they go out, people know what is their status. And there's also a lack of involvement and empowerment of people living with HIV and AIDS. What might be the cause? It might be the precarity that that the Haitian are living in. And as you may know, 6 million people, 6 million Haitians are living below the poverty line. And also there is constant social stigma and discrimination. So all of this shows that Haiti is far from achieving the second and third pillar of 95 goal to control the HIV epidemic. Next slide, please. Okay, so we launched this campaign that we call A égale A in French, E equals E, or U equals U. In Creole, we would say indétectable égale intransmissible. As I said, it is a campaign. It is a campaign to increase the awareness on ART and also increase the percentage of people living with HIV and AIDS who are placed on ART to achieve HIV viral load suppression. Next, please. Okay, we do implement the campaign with the collaboration of the national program, with the Ministry of Health, with the funding from USAID and PEPFAR. Next slide, please. Okay. Well, what is our strategy? We do work with social and traditional media, influencers, artists, events promoters to get the message out to the target audience. Haiti is a special country in many sense. Haiti has more than 700 radio stations. And if you just divide the population of 11.4 million by 700 radio stations, you would see how many people listen to radio station in Haiti. I mean, it's true that not all radio has the same level of audience, but according to the most recent data, more than 80% of Haitians listen to the radio station, either news, politics, religion, or music. And also, we do work directly with people who are impacted, with people who are HIV infected, and as well as other implementing partners working in the field of HIV and AIDS. Please move on with the slides. Okay. Okay. Now, through the workshop that we organize with the people who are living with HIV and AIDS, so they help design the message, or they make sure that the message is fit, and also they decide on which influencers that they want to use, to pass on the message. Next slide, please. Okay, this is an ongoing campaign, but this is what we have been able to accomplish for the past 3 months. And as I said, the key messages are delivered from the own voice of people living with HIV and AIDS. So we have out 5 public service announcements, PSA, and 2 short video testimonies. And they are being broadcast nationwide through radios, TV, social media. So far we have about 200,000 combined views, and around 100,000 people were sensitized through different communication activities. When we launched the campaign in Petit Goâve is in the West Department, so there was a very huge musical festival, and there were many very famous artists for the lineup. And we had a chance to go in front of the public. It was huge. I mean, it was phenomenal, to broadcast on big screen those messages to this huge crowd. And the spots, the video spot that we produce, we do organize viewing and training session for youth, and we reach out 1,000 participants, including women, people who are living with HIV and AIDS, community leaders, religious leaders, young students. And they were able to reflect their views, to say what they like and what they didn't like. But at the end, they learn a lot from the process, because now they said that they feel less HIV and AIDS, because they didn't know that there were all of these positive voices, these positive stories behind HIV and AIDS. And also we put banners and billboard at the corners of the main street, where even if you are driving, where it's a must to take a look or stop and see what is written on the banner. Let's move to the next slide. Okay, now we are going to play a short video. So this guy, we were very patient with him when we were registering this, when we were recording this video. He wanted to do it, but it takes time, to provide him the coaching. And yeah, can we play the video, please? Can we click on the link to play the video?
It was working when we tested it, so I'm hoping we can make that possible. Well, if it doesn't seem like it's possible to be able to watch the video, I wonder if Mr. Jean-Claude, if you can describe to us what happens in the video.
Okay, or can I? Is it possible to share my screen, because I have it on my file.
I don't think it is.
Okay. Okay. Well, in this video, I mean, this is a video spot on adherence. I mean, it is a testimony from him. So where he explained the importance of remaining on ART. He's explaining that he's leading a normal life with his family, and he does sport and letting out the message that even though he's on ART, he has hopes, and it doesn't mean that his life is going to be over. And at the end, it's a very positive message. It's a message of hope that he wanted to pass on to the population and to other people who are in the same situation like him. So this is more or less what is in the video. This is a very short video.
So maybe we go ahead with the presentation right now, and then hopefully we can try to come back to the video.
Okay. And
Thank you.
well, we can move on to the next slide.
Okay, can we move on to the next slide, please, if we're not able to connect to the video at this time? Thank you.
Okay, now we're at the end, but there are some lessons learned, and we will keep building on these. What we have found out is that working directly with people who are living with HIV and AIDS by putting forward their own voice, it brings credibility to the message. They choose influencers they feel that are best suitable for their cause. And honestly, when we are playing the videos, many people say, "Are you sure that these people are HIV infected? They don't look like that they are infected." And I remember one story, I think it was in Saint Mark, where one person, who listened, who was viewing the videos. So he said, "I am going to go back on treatment," because he was a loss to follow up, because he was discouraged. And he said, this video, because there was one video on stigmatization and discrimination. He said, "This video has brought me new hope. So I am going to go back to the health center, to go back on my medication." And the other lessons learned is that more other people who are living with HIV are encouraged to be more involved, because they said that, well, if those people can do it, we can do it too. We want to fight passivity, we want to save, we want to celebrate lives, and we want to be carrying a message of hope. And from what we find, from what we collect, from testimonies we collect from our viewing session, many people have another perspective regarding HIV and AIDS. So they were not aware that there was something called U equals U, or A equals A. And even at the religious leaders, the pastors, the priests, the traditional leaders, where sometimes people would go when they are HIV infected, if they are afraid to go elsewhere. They said that the message is reassuring to know that there is no more fear of HIV and AIDS. And also the last point I want to mention to conclude is that the communication material that we generate, they have created demand for many HIV networks or asking for them. The health centers, they want them to put on the TVs, on the outpatient clinic. So it is an ongoing campaign, and we are trying to consolidate on these assets. And pretty soon we will come out with a jingle, with a song that we will be distributing through the country, playing for the artists at the radio station. And let's go to the last slide, and I think it's really the last one. Okay, so now tell me, whoever is driving on the road will not stop to see, or will not take a look to look at this picture. I mean, that says, yes, well, there's the lady, that's one thing, but also the message is up there. U equals you, take your medication every day, because zéro gemme sida dans sang égale zéro transmission. It means that undetectable equals untransmissible. Thank you so much.
Thank you. And just to share, I'm sorry that the video didn't work out, but in the chat box, we do have the link to the video, and definitely recommend everyone to take a moment after this session to watch the video. It's quick and it's very informative and well done. Thank you.
Okay. Thank you.
Thank you so much, Mr. Jean-Claude Luis. That was an excellent presentation. And we know that U equals U is a really pertinent topic. So many countries are looking at implementing U equals U, and it's really quite amazing what you've done in Haiti and during the COVID-19 epidemic to get out the message to people across the country about ART, about the U equals U message. So really congratulations, and thank you so much for that example. I hope that our colleagues will post some questions in the chat box, and we'll get to hear more from you after our second presentation. So thank you.
Thank you, Nicole.
Yeah, Dr. Yoop. So our next presenter, as I mentioned earlier, is Dr. Joep van Oosterhout. His presentation is entitled Partners in Hope Malawi Achieves Acceleration of Pediatric ART Optimization During the COVID-19 Epidemic. And we will hand it over to you, Dr. Yoop.
Thank you, Nicole, and thank you, everybody, and thank you for inviting us to present here. My name is Joep van Oosterhout. I'm a physician, and I work as a clinical director at Partners in Hope Malawi. So I'm going to switch off my, that it may compromise the connection, the online connection that we have. Right. So I'll be presenting on behalf of colleagues at Partners in Hope, and the title of my presentation is Partners in Hope in Malawi Achieves Acceleration of Pediatric ART Optimization During the COVID-19 Epidemic. Next slide, please. Oh, I can see that we're already at the next slide. Could you go back one slide, please? Thank you. So Partners in Hope Malawi is a local Christian medical non-governmental organization. We have a high-quality medical facility in Lilongwe with a molecular laboratory that supports the National HIV Program. We're also an implementing partner of USAID, and we are supporting HIV programming in 101 health facilities in 8 districts, as you can see there on the map, quite dispersed over the country. Next slide, please. Transitioning children and adolescents to more effective ART regimens and drug formulations is important to achieve the third 95 in these age groups. And this is illustrated well by the graph below, with data from the 101 health facilities that we support at the time of the start of the COVID-19 epidemic. The graph on the left shows females, and the males are on the left, and age categories are on the x-axis. I think you may not be able to see that on this slide very well. But what you can see is that viral load suppression, defined as viral load less than 1,000 copies per milliliter, is much lower in the age groups between 1 to 19 years than it is in adults, and with particularly poor results in the youngest children. Next slide, please. So, transition to optimal ART regimens is crucial. But while aiming for simplification, transition guidelines turn out to be quite complicated for providers in the field in Malawi. And there's a number of factors contributing to that, and here they are. First of all, ART care is largely task shifted. Further, 2 sets of guidelines were introduced, one in 2018, and soon after an extensive addendum in 2019. And these guidelines introduced
Dr. Yoop, I think we have lost your audio.
Dr. Yoop, are you there?
Yes, I'm there.
Okay, great.
Yes, so I think I will resume, and I'll pick it up where I was going to say that transition guidance turns out to be quite complicated for providers in the field in Malawi. And here are some of the contributing factors to that. First of all, ART care in Malawi is largely task shifted. And then 2 sets of guidelines were introduced recently, one after the other. One in 2018, and then quite an extensive addendum in 2019. And these guidelines introduced an increasing number of ART regimens with new drugs and new drug formulations. It's also complicated for providers in the field that the blurring of the traditional distinction between first and second line regimens has occurred. And then in April 2020, at the start of the COVID epidemic, training gatherings were suspended due to COVID-19 restrictions. And because Partners in Hope had not yet completed pediatric ART trainings at that point, many providers felt ill-prepared to implement ART optimization transitions. Next slide, please. PIH then introduced a number of interventions to accelerate pediatric ART optimization. We developed a self-orientation package that included a slide set, a video, standard operating procedures, a quiz, and a number of case scenarios. We are grateful for the collaboration with our fellow implementing partner, Baylor College of Medicine, Malawi, in developing this. The implementation of the orientations was facilitated by on-site Partners in Hope mentoring teams. We then also started attaching individual ART optimization recommendations to all treatment cards of children who are still on non-optimized regimens. And Partners in Hope clinical mentors actively followed children and adolescents on non-optimized regimens as they took responsibility for full optimization of the cohort that they were overseeing. Next slide, please. Next slide, please. Partners in Hope evaluated the pediatric ART self-orientations and found that participant healthcare workers appreciated it highly. They also mentioned that it had imparted them with the required knowledge to implement pediatric ART optimization. Next slide, please. This slide is based on Ministry of Health data that demonstrate progressive pediatric ART optimization over time from Q1 to Q4 of COP19. The bars show percentages of patients on pediatric ART regimens. Orange indicates protease inhibitor-based regimens, blue NNRTI-based, and gray dolutegravir-based pediatric ART regimens. Q4 data are not complete, but they suggest that more than 90% of pediatric ART regimens are optimized. Next slide, please. Partners in Hope also started collecting more detailed pediatric data from 57 health facilities between July and September 2020. And with that, they found that more than 90% of children aged 1 to 19 were either on a protease inhibitor or a dolutegravir-based regimen. And of the 9% of children on NNRTI-based regimens, more than half had an undetectable viral load. And local recommendations say that if such children are clinically well and have no side effects, they may continue this regimen during the COVID-19 epidemic to avoid frequent health facility visits that are required after a regimen change. Next slide, please. And this slide demonstrates improving viral load suppression during progressive ART optimization between June and August 2020. These data are from the Malawi Laboratory Information Management System. And the lines indicate increasing percentages with suppressed viral load, again, defined as viral load with less than 1,000 copies per milliliter in 4 age categories, as you can see at the bottom of the slide. I'm not sure if that's presented well on this occasion. I want to place some notes here at this slide. First of all, viral load suppression will lag behind ART regimen optimization. That is logical. Further, the highest age group has high dolutegravir coverage, but even so, viral load suppression is considerably lower than among adults. But the lowest age groups really remain most problematic. And we believe this is mainly due to the drug formulations that are available to them. Lopinavir granules for the youngest and smallest children, they are an improvement compared to the pellet formulations, but they really remain far from ideal. And I'm just mentioning a few of the challenges with granules here. So first of all, the instructions for caregivers are not straightforward. Granules have a high pill, or if you want, sachet burden, and this is especially difficult for the slightly older children, some of whom have to take 5 sachets twice daily. Palatability of granules is not great, and side effects, although they're generally not severe, they can be cumbersome. For instance, vomiting, and children could start refusing the medication once they've experienced that. Granules should be taken with a variety of foods, but the socioeconomic circumstances in our setting can make that quite difficult. Given these challenges, further measures may be needed for children on granules, such as the establishment of dedicated clinics for children on Granules, and community support groups. But of course, a great hope is placed on the introduction of pediatric dolutegravir in the coming months. Next slide, please. I'm coming to my conclusion. Partners in Hope accelerated pediatric ART optimization during the COVID-19 epidemic with self-orientations to equip healthcare workers with adequate knowledge. We combine this with intensified follow-up of individuals who are not yet on optimized regimens. And Partners in Hope is now well on course to achieving full pediatric ART optimization at the end of September 2020. This is then expected to improve viral load suppression further, but that might also require more interventions to achieve optimal third 95 results. Next slide, and that's my last slide. Thank you very much for your attention, and I'm looking forward to further discussion in the panel. Thanks, Nicole and Megan, and I'm handing it back to you.
Thank you so much, Dr. Yu, for that really great presentation. It's really impressive what Partners in Hope has achieved with 90% optimized regimens for children in Malawi. It's a really exciting progress, particularly during the last few months, which has been a difficult time, we know, in Malawi and around the world. And I just wanted to also note, particularly showing your results for the youngest children and sharing your experience with the challenges with the lopinavir granules. I think that is a common experience in many countries, and we really look forward to the new dolutegravir 10 milligram dispersible tablets, which will be available, should be available in 2021. We're hoping that the FDA approves them by the end of this calendar year and that they become available between April and July and fully by July of 2021. That is our hope and expectation, and we are planning for that. That would be the next transition, which we think will be a substantial improvement for particularly the youngest children. And we know it's a more effective regimen, the most effective regimen so far, and also it'll be simpler and more cost effective. So we look forward to yet another pediatric treatment transition, but this one we think will be a durable and more effective one. And hopefully we can have a little bit of discussion about that as well. I see the poll has gone up, but perhaps it looks like we may be able to present on the very short video.
Can we also vote, Nicole?
Of course, yes. Go ahead. So Megan, would you like to try to go ahead and present the video, and we can continue with the discussion?
Yes, I'm going to try to share my screen in order to for us to present the video. So I am going to take others off of video right now in order to just be able to do that. 1 second. Okay, can everyone see my screen? Or
Yes, we can.
okay, thanks.
Looks like technological challenges are really getting to us today.
Is it not playing?
No, I don't see it.
Oh, sorry. I thought it was playing on my screen. You don't see the video popped up?
Okay, can you click on the picture maybe?
What are you guys seeing? Sorry, I'm not able to.
Just
Yeah,
the
I mean,
PowerPoint slide.
just the picture.
Okay. Yes, the video had started. I thought everyone was watching it. Apologies, and I can't. I'm sharing my screen. I can't see the chat. So let me just try one more time quickly here. But it looks like it may not work.
Suggestion is if you have the option to share your desktop to show the video.
Okay, it's playing. Oh, okay, it's playing now.
Is it playing?
Yes.
Should there be audio though?
Do you not hear the video?
Yeah, I wish, but there is no audio.
Do you see the subtitles though?
Yes.
Okay,
Yes, we
I
can see
think
the subtitles.
we'll just move forward with that, considering the time we have now. So.
Great, thank you. Thanks, Megan. And I would encourage everyone to go to the Vimeo. We put in the link earlier in the chat, and maybe one of my colleagues can pull it and bring it to the end of the chat. I know that we will be, our session is ending soon. I posed a few questions for participants. Thanks for that, Nimasha. You can see the video at the Vimeo slides. Maybe for you, Mr. Jean-Claude Luis, maybe you can tell us how you managed to put together such an impressive national multimedia campaign that reached 200,000 people during the COVID epidemic. That must have been a real challenge, and it looks like quite an impressive feat. So maybe you could just speak a little bit more about how you managed to do that.
Okay. Well, you know, Haitians have been very skeptical of COVID. I mean, they know that COVID was around, but I mean, if you are circulating in the street in Haiti, I mean, you would see some people going without masks. I mean, even though COVID was around. But the thing is, at the end of July, the government lifted the state of emergency, you know, to allow more people to gather. I mean, it doesn't mean that COVID was gone. But when we launched the campaign in Petit Guave, there was the Fête Notre Dame, Our Lady. I mean, which is a very well celebrated, well, traditional party in Haiti. So there was a very huge lineup of famous musicians, and there must have been over 150,000 people at this crowd, and you couldn't even walk through the crowd. So we were on the stage, few of us. So we show some of the videos, and people were very happy to see them. That's one, I mean, that's one step. And then the other thing is we do work with influencers. We have 4 general influencers. So they have many followers on social media, on Instagram and on Facebook. And, people are passing on the videos. And we cannot even assess how many people have viewed them on TV, because we have them on TVs, we have them on the media. I said that Haiti has 700 media, so we have no funds to broadcast on every media. But at least we got 20 radio stations that were broadcasting, the audio particularly, plus the videos on a few TV. So there might even be more people who have seen the videos and the audios.
It's very impressive, and we look forward to hearing more from you in the future as you evaluate further the impact of this campaign and the feedback and response from recipients of care. We know you've done some focus group discussions, and we look forward to hearing more about your success in this. And maybe for Dr. Yup as well, your pediatric treatment optimization has gone really well and quite rapidly, and you shared with us some of the challenges. And I mentioned I mentioned the dolutegravir transition next year. Do you think you could speak a little bit to how you think that may help improve your viral load suppression and treatment of particularly the youngest children? Are you still with us, Dr. Yup?
Yes, I couldn't really follow your question, I'm afraid, Nicole.
I wondered whether you could, because I know you are also following the science and the plans. I'm wondering whether you have started discussing the dolutegravir 10 milligram dispersible tablet introduction in 2021 and how you think that may continue to improve your pediatric treatment optimization.
Nicole, I think that'll be a revolution. Yeah, I think some of these challenges with granules are quite demanding, especially in our setting. I think there are challenges related to the health system, challenges related to providers, challenges related to caregivers, and challenges related to the children. And they all add up to quite a considerable effort that is required to overcome these. I'm not saying it's impossible to do, but it's very labor intensive. And my experience is that for the best guarantee of success, interventions need to be quite straightforward and not complicated to enable the task-shifted force in the field to execute the implementation well. And I think the conditions for pediatric dolutegravir seem much more in line with those conditions. So really, we're looking forward to the introduction of pediatric dolutegravir. That doesn't mean to say that there will be challenges at that point, because with those suboptimal regimens, there will be children with various stages of ART failure, potentially with HIV drug resistance, and then they might switch from a failing regimen where there is drug resistance to the NRTI backbone to the slightly different or the same NRTI backbone with the dolutegravir, and that could induce a risk of developing dolutegravir in the future. So some of these challenges are there, and it will need clever solutions for us to try and resolve that. But I still feel that this is the biggest opportunity for us to achieve much better results in the younger age groups. So that wouldn't stop us from, as we wait for pediatric dolutegravir to be introduced, to try and make the best of it. And I provided some measures that we could do in the meantime, such as dedicated clinics and community-based support groups, trying to improve the recommendations that we give and the explanations that we give to caregivers, how to best to do that, to really support them, not blame them when things are not ideal. So in the meantime, I think there are ways to improving the outcomes of granules. But all the same, I think the major promise is from, to me personally, the major promise comes from pediatric dolutegravir.
Wonderful. I think that's a really great note to end this session. We do have a 3-question Zoom poll. Please take a minute and complete the poll and give us feedback. I think this has been a really good discussion, and I'm glad to end on a really hopeful note as we continue to optimize treatment, inform our beneficiaries. Both of these sessions really show how these two aspects are important to contribute to our treatment optimization and continue to improve the quality of care for adults and children and families living with HIV. So we thank you, both of the presenters, very strong local organizations who've shown us the amazing work that they've done in very different parts of the world. And so we are grateful for your hard work, your dedication, and your presentations today.
Very much, Nicole, and
Thank you.
we are very pleased to share with you, and the audience a sample of our work. So we really appreciate it. Thank you.
Yes,
Thank you so much, Nicole and Megan, for leading the session, and we've enjoyed taking part. Thank you very much.
Thank you very much for presenting. Sorry about some of the hiccups on the tech side, but we really appreciate the presentations today and the discussion. Everyone, thank you.